Assalamu alaikum wa rahmatullahi wa barakatuh. We will continue our talk about the anatomy pertinent to urology or to symptomatology in urology. In this part, we will cover the urinary bladder. Now, as we have said, the urinary tract is divided into the upper urinary tract, composed of kidneys and ureters. The lower urinary tract is composed of urinary bladder and the urethra. Now, the urinary bladder can be simply described as a reservoir. It receives the fluid coming from the upper urinary tract and store it until appropriate time for voiding. The shape and the size of the urinary bladder and position and relations to other organs or structures vary according to its content and the state of neighboring viscera also. When the bladder is empty, it lies entirely in the lesser pelvis below the peritoneum, and as it distends, it expands anterior-superiorly into the abdominal cavity. Now, an empty bladder, like depicted in this picture, is somewhat tetrahedral in shape, and it has a base. The base is the same as the fundus, so it's called the fundus, and it has a neck and an apex. The apex is going anteriorly, and a superior dome. Also, two lateral side walls, which are located inferior-laterally. The inferior-lateral surfaces are the two lateral sides. Now, the base of the bladder, the fundus, is a triangular in shape, inverted triangle, and located inferiorly. The neck, the bladder neck, is the most fixed part, and it lies most inferiorly to aid with emptying the bladder, about 3 to 4 centimeters behind the lower part of the symphysis pubis, and it is of course just above the plane of the inferior aperture of the lesser pelvis. The bladder neck is essentially is having the internal urethral orifice, which lies in a constant position, as we have said, and this position is independent of the varying positions of the bladder and rectum. Now, in males, the bladder neck rests immediately on the prostate and is in direct continuity. So it has direct continuity with the base of the prostate, while in females it is related to the pelvic fascia that surrounds the upper urethra, and in both sexes the apex of the bladder faces anteriorly toward the upper part of the symphysis pubis, and the apex has a structure that is called the median umbilical ligament, or the urachus. The median umbilical ligament ascends behind the anterior abdominal wall from the apex to the umbilicus, covered by the peritoneum. So it's a pre-peritoneal structure, and we can call it also the median umbilical fold when we are looking from the inside of the abdomen, inside the abdominal cavity, intraperitoneally. Also, as you know, we have also the two medial umbilical ligaments and two lateral umbilical ligaments. Now, the anterior surface of the urinary bladder, which is toward the abdominal wall, is separated from the transversalis fascia by a fatty tissue or adipose tissue, forming a potential retropubic space. We call it the space of Freezius. The space of Freezius has an importance in approaching the bladder anteriorly and also approaching the prostate. Here we have an empty bladder in this photo, and as the bladder fills up, it becomes ovoid in shape. And anteriorly, it displaces the parietal peritoneum that is normally is there on the upper on the dome of the bladder and the posterior part of the posterior wall. It displaces the peritoneum from the suprapubic area of the abdominal wall. By displacing the parietal peritoneum, it displaces also the intraperitoneal structures and organs such as the colon and the bowel. Now, normally it can reach up to 5 to 7 centimeters above the edge of the symphysis pubis. This is the symphysis pubis. Now, this distension of the urinary bladder can be useful in puncturing the bladder in the suprapubic area. We call it the suprapubic cystostomy if we have put a drainage tube, or the cystofix, a common name that is well known, the cystofix. So this is this relations that is very useful in clinical practice. But of course, this normal alignment of structures can be distorted by previous surgeries in the lower abdomen. So it's preferable to check the bladder if it is full or not by using an ultrasound. Now, the urinary bladder mucosa, almost all the urinary bladder mucosa in the body of the bladder is attached only loosely to the subjacent muscles. So it can be separated in some of the procedures of in urology. When the bladder is empty, it folds within the bladder, making mucosal folds. And those folds stretched flat as it fills. It becomes smooth. Except in the trigonal area, over the trigon. The trigon starts from the internal urethral orifice. So, and it is immediately above the internal urethral orifice and posterior, behind it. The mucosa becomes adherent to the underlying muscles, and it is always smooth. That's why the trigonal area is usually well demarcated from the rest of the urinary bladder mucosa, especially in cystoscopy. Now, the anterior-inferior angle of the trigon is formed by the internal urethral orifice, as we have said, and the trigon is also inverted triangle, and on the posterior lateral angles of the trigon we have the ureteric orifices. Now, also the superior boundary of the trigon is slightly curved and forming the interureteric bar. There is a ridge that is called interureteric bar. It has also different names like Mercier's bar, or the bar of Mercier, which connects the two ureteric orifices with each other, and it is a direct continuation. It forms a direct continuation to the vesical wall of the ureteric internal longitudinal muscles around the ureters. Also in the trigon, the smooth muscle of the trigon consists of two distinct layers only, not like the rest of the detrusor muscle. The rest of the detrusor muscle has inner longitudinal, middle circular, and outer longitudinal, while in the trigon we have the superficial trigonal muscular layer, which is superficial to the inside of the bladder from the cystoscopic view, and we have the deep trigonal muscular layer. The deep is continuous with the rest of the detrusor muscle, and it is indistinct from it, while the superficial is morphologically distinct, and unlike the detrusor muscle, it is composed of smaller muscular fibers, and it is, as we have said, continuous with the muscular layer of the intramural ureters. And in the urethra, it is also continuous with the urethral musculature in both sexes, in males and in females. In males also it can extend much distal along the urethral crest. We will talk about the urethral crest in the urethra. It can extend this superficial muscular layer of the trigon reaching up to the utricle, or the both openings of the ejaculatory ducts. The urethral orifices are usually slit-like openings in the posterolateral trigonal angles, and when the bladder is empty, the distance between the two ureteric urethral orifices is about 2.5 centimeters, and also the distance between the ureteric orifice and the internal urethral opening is also about 2.5 centimeters, and of course this distance maybe it doubles on the full bladder. Now the bladder neck is somehow different between males and in females. In females, the bladder neck is morphologically distinct smooth muscles. So it is distinct from the detrusor muscle of the bladder, but it is continuous with it. It has a smaller diameter fasciculi, muscular fasciculi, and extends obliquely and longitudinally along the urethra. So in normal females, the bladder neck sits above the pelvic floor and supported by pubovesical ligaments and endopelvic fascia of the pelvic floor and the levator ani, which is forming, of course, the continent mechanism. When the intra-abdominal pressure increases in the normal anatomy, the levator ani also contracts, helping with urethral closure with coughing or sneezing, and this maintains the continence. Now, a common problem in females, especially after multiple pregnancies, the bladder neck starts to lie beneath the pelvic floor, which we call it prolapse. And in this case, when the intra-abdominal pressure rises, the levator ani contracts above the urethral continence area, so stress incontinence start to happen with females. A bladder neck in males also is different. It is completely surrounded by a circular collar of smooth muscles, and this circular smooth muscles has its own distinct adrenergic innervation and extends distally to surround the pre-prostatic portion of the urethra. We will talk about this pre-prostatic portion in the urethra. So the pre-prostatic portion has this circular collar of smooth muscles, and those muscles are also distinct from the smooth muscle bundles of the rest of the detrusor muscle, and they form what we call it the pre-prostatic sphincter. They are also small in size compared to the detrusor muscle fasciculi, and they have also larger connective tissue component, and it is rich with elastic tissue to allow in distension. And the bladder neck in this area sometimes is called, or usually called by urologists, as the internal sphincter mechanism. So it's different from the external sphincter mechanism in the urethra. It's an internal sphincter mechanism. We distinguish it from the distal urinary sphincter mechanism. Now, the internal sphincter contributes to urinary incontinence in males. And even sometimes, if we have a malfunction or injury to distal sphincter in the male, sometimes this internal sphincter mechanism alone can maintain the continence in male. And unlike the detrusor muscle and the rest of the urethral smooth muscle, the pre-prostatic sphincter is also richly supplied with sympathetic noradrenergic nerves, and it is almost devoid of parasympathetic cholinergic nerves. Finally, I would like to thank you again for listening for this part. I hope it will aid us in understanding or better understanding for the symptoms in the urinary tract.